What's going on, guys? Tony Maritato here. Welcome to Learn Medicare Billing. So in this tutorial, and that's what it is, it's a tutorial, I'm going to take you into the Medicare Benefit Policy Manual. We're going to specifically go down to section 220.2 where it discusses medical necessity, and I'm going to start reviewing some of the examples within the maintenance section so that you could start to get a handle on how you determine what is medically necessary in terms of a covered service, what's not, and how you can use that information to help leverage and grow the hybrid part of your practice. Now, if you're not familiar with the term a hybrid practice, basically the way I'm using it is that you have a practice that combines the benefits and easy access of using the third-party payer system. So let's say, for example, you chose to become a participating or non-participating provider with Medicare because you know that that population desperately needs your services and has limitations on how they can access your services. You became par or non-par with Medicare, but you also know that for the kind of business model you're not running a higher volume, larger corporate-based clinic. You're running a really specific, smaller niche-based practice, and you can't afford to treat a full caseload at the Medicare allowed amount. So you need a way to supplement and combine the benefits and the easy access of the third-party system along with the higher reimbursement of a cash-based, direct pay, self-pay market. And so we're going to get into the Medicare guidelines. We're going to look at the Medicare documentation, and we're going to dissect that a little bit to see if we can find the hidden opportunities that allow you to leverage what you do best, grow your practice, but maintain your compliance so you're not violating any rules. So guys, let's jump in here. Let's look at the first example under the maintenance section. I'll show you where it is, and then we're going to talk about it. Okay, because I think there's a lot of hidden value here that I really haven't heard any of the mainstream, presenters talking about. So guys, let's check it out. Okay, so we're in Google. We're just going to do, if you haven't seen me do this before, super simple, CMS Chapter 15, Medicare Benefit Policy Manual. You're going to click on that, and this is what the first page looks like. If you scroll down to section 220, you can see right here, section 220, what we're looking for is 220.2, reasonable and necessary outpatient rehabilitation therapy services. And this is specific to, it's not specific to PT. This is PT, OT, and speech all represented in this section. I'm going to go ahead and zoom in here just a bit, and let's scroll down. This is a super important section. What is reasonable and necessary? That deserves a video all unto itself, but I'm not doing that today. We want to get down here to the maintenance section, and we're going to look at some of the published examples. So let's take a look at example number 1 right here. And guys, I hate to read to you, but I'm going to do it because it's just that important. So example 1 reflects a typical outpatient scenario in which a patient has been receiving ongoing therapy under a physical therapy plan of care, and the physical therapist begins the establishment of a maintenance program prior to the patient's anticipated discharge date. Okay, so let's talk about just a couple components here. Yes, maintenance programs are covered by Medicare as long as the maintenance is medically necessary. And that's where the definition becomes really important. Establishing a maintenance program, the evaluation, the assessment of the information that you collect, education, all that stuff is medically necessary in a covered service. But the actual administration of the program may not be a covered service. Now in this example, well, let's just get into it. How about that? Okay, so patient with Parkinson's, and I think you guys are going to relate to this. A patient with Parkinson's is nearing the end of a rehabilitative physical therapy program and requires the services of physical therapist the last weeks of treatment to determine what type of exercise, right? Determine what type of exercise will contribute the most to maintaining function or preventing or slowing further deterioration of the patient's present functional level. That's a really important component here. when we're looking at ruling out medical necessity. Patient's present functional level following cessation of treatment. In such situations, the establishment of a maintenance program appropriate to the capacity and tolerance of the patient may be, by the qualified therapist. The instruction of the patient or family members carrying out the program, and the reassessment or reevaluations as may be required may constitute covered therapy because of the need for skills of a qualified physical therapist, or any therapist, OT, PT, speech. So those are the three components here that they outline that are determining, these sessions, this session is medically necessary because it requires the skills, the education of a licensed clinician. Now, what is not covered service is the actual implementation of that program. Following the patient around, counting the reps, counting the sets, motivating the patient. These are all non-covered services, assuming there's no significant medical condition, comorbidity, risk of further injury, changes. We're going to talk in the next video about a situation where there's an unstable fracture and maintenance is maintenance does show medical necessity, but this section and the following example are going to kind of go to illustrate it's not always medically necessary. Okay. So in this scenario, basically Medicare is saying, look, we're going to pay for the creation of the program. We're going to pay for the education of the client, the family members, the caregivers, and we're going to pay for the assessment, reassessment, evaluation component. But that's it. It's done after that. To further illustrate when something is not medically necessary, let's look at example number 2, because this gets even more specific. I really like this example. So example 2 is an outpatient scenario in which a patient who has not been receiving ongoing therapy under a therapy plan of care needs a maintenance plan. Okay, so let me see that again. An outpatient scenario in which a patient who has not been receiving ongoing therapy under a plan of care needs a maintenance plan. Okay, so this is patients being referred to you, they haven't been in therapy, but they don't really need therapy, they need a maintenance plan, right? So in this scenario, a patient with MS, okay, so they have a diagnosis, needs a maintenance program to slow or prevent the deterioration in communication. Speech therapists, listen up. Communication ability caused by the medical condition. Therapy services from a qualified speech therapist may be covered to establish a maintenance program even though the patient's current medical condition does not yet justify the need for individual skilled therapy sessions. Again, the evaluation, the establishment of the program, and training the family or support personnel may require skills of a therapist and would be covered. Okay, note, in this example, the skills of a therapist are not required to actually carry out the maintenance program services and as a result are not covered. And this is where we get into that sweet spot where we're combining cash-based services and covered services. So you get a scenario like this, a patient's referred to you. Let's take one example. I was going to say 2, but let's just take one example. Patient's referred to you. Okay, this individual, in fact, today, literally today, what is this? It's August 1st. August 1st, I had a new patient evaluation today. Now, this was a gentleman I had seen multiple times in the past. Probably over the last 3 years. I treated his wife, I've treated him. Okay, he had a spinal surgery just over a year ago. The surgery went fine. It did not resolve the symptoms he was experiencing. But there's no complications, there was no other problems. Now listen to the history of this person. So this person had some lateral hip pain radiating down kind of the L3 dermatome. The pain was reproducible with palpation along like the medial quad. I thought sartorius, I thought quad strain. He believed that the onset of his symptoms occurred when he was getting off an elliptical, he misstepped, he twisted and kind of jerked his back, but felt it in his thigh, his anterior thigh. Okay, this was a long time ago, multiple months ago. It hasn't changed, it hasn't resolved. Okay, so what now? He has no other medical comorbidities. This is an active individual living independently, lives with his wife. He travels to Florida multiple times throughout the year. He still goes to the gym 3 to 5 days a week. He works out, he does 30 minutes of cardio, he does 20 minutes on the machines. He enjoys being active. He plays golf, he plays some recreational tennis, he hangs out with his family and his children. There is zero comorbidities that are going on. Heart healthy, lungs are healthy, no diabetes, not obese, no other complications, no obvious risk of any kind of further injury, no history of falls. I mean, just nothing. The guy is generally healthy. He just has this anterior thigh pain. It's been going on for several months. There's no imminent risk of further damage. I did a physical therapy evaluation. It was a covered service. I created a plan of care for this individual. We set goals together. We talked about what his plans are, what he wants to achieve. That was all covered service. Now from here forward, everything he does with me is going to be cash pay. And within the established plan of care, I've ruled out all of those other things that I stated. He has no cognitive deficits. He has no problem with memory or retention or learning. When I show him 3 exercises, he can repeat those 3 exercises without problem. And I know this individual, next week, he's still going to be doing those 3 exercises. Like, he has no learning deficit, no reason for me to believe that he can't carry out my program independently, or with a personal trainer, or with a licensed massage therapist, or anybody else of his choosing. Now, he's choosing to work with me. We have a long-standing relationship. We have a level of trust, a rapport. He wants me to guide him through the day-to-day treatment, through the day-to-day program. That is not a covered service. That is all direct pay, self-pay, outside the scope of what Medicare should cover. Now, if we wanted, at some point, maybe we're going to do a reassessment, an official reassessment in the medical record to determine his progress. That would be a skilled service. That would be something that would be billable through the Medicare system, reimbursed by Medicare as a covered service. If we did a discharge summary, he reached his goals and he doesn't want to continue to pay out of pocket, he wants something sent over to the physician, you know, all of these things. Again, a covered service, because I'm going to be doing the skilled service of assessing his progress, his range of motion, you know, monitoring kind of the entire situation, the context, like what is he doing personally, socially, work. That's all requires the skill of a clinician and writing up the report. But everything between those sessions are all self-pay, direct pay. They do not fall under the umbrella of Medicare. And so that's where, if you're looking at, you know, a situation where, let's say, typical reimbursement, if you watched my reimbursement video, you know these numbers, but I'm going to post it up here. The link will come out in a second. But let's just say a typical standard evaluation and treatment that's medically necessary, a covered service, total reimbursement to you, your practice is, I'm just saying, $125. Okay, we've got $125 that came in. Now let's say this gentleman is going to come on and he's going to do one-on-one, you know, whatever you want to call it, personal training, wellness, performance, whatever terminology you want to use. And it's going to be at a rate of $250 a session. Now, don't get freaked out. I know some of you are like, $250, who's going to pay something like that? There's a lot of wiggle room in what is included in that $250 a session. That could be once a week, that could be once every other week. That could include full access to your facility. So maybe this gentleman's going to come in 5 days a week and you're going to do one-on-one session with him, but then the rest of the time he's going to be working out on his own. You know, there are plenty of CrossFit gyms in my area that are charging $250 a month. You don't get any one-on-one sessions, and it's just to come in and do the classes. So don't let the price kind of freak you out. But what I'm going to say is, let's just say in this package, we end up doing 4 one-on-one sessions at $250. That's going to put $1,000 of revenue into your bank account. And then we're going to do the 5th, which really was the first session, as a covered service at $125. So now for 5 sessions, 5 hours of your time, you're going to be looking at a total collection rate of $1,125. You dollar cost average that, I think that's a pretty respectable income. And the reason why you're able to do that is because you can combine the benefits of being in the Medicare network, being a participating or non-participating provider with Medicare, allowing the beneficiary access to you through that network and utilizing the benefits that they've paid for. But then once you've completed that initial evaluation, developed the plan of care, now the real business acumen kind of kicks in, and it's time to say, look, Mr. Patient, unfortunately, Medicare coverage policy allows me to perform today's session, but it does not cover or reimburse for subsequent sessions because it's determined that it's not medically necessary. And so if you'd like to continue working with me, this is the rate. If you would like to take this program and do it on your own or do it with a personal trainer or somebody else, then today's session is going to be processed through Medicare and secondary and so on. And then we can follow up as needed. So there's systems to take this to the next level. But my goal today is really to just drill down, show you where to look for the documentation, show you where to find the resources that support your decision, and then really encourage you to start developing those internal policies. Start putting pen to paper, typing up those policies that say, look, this is for my business how we determine medical necessity based on CMS Chapter 15 Medicare Benefit Policy Manual, Section 220.2, paragraph whatever, clearly states this. Based on that information, we've determined this, and this. Hence, the following care is not medically necessary and will be offered to the beneficiary on a self-pay rate, right? So you have something backing you up, backing up your decision, your staff's decision, and it shows how the business operates with these resources. Because I can tell you that if you don't have something like that in place, you're just kind of flying by the seat of your pants, and then you don't have support to back up the decisions you're making. So guys, I'm talking your head off right now. This is a small part of a new series that I'm working on, where I'm trying to pull together the resources to help you build the caseload that you want at the revenue point that you need. Because basically, my hunch is you didn't become a clinician because you wanted to get rich. You didn't become a clinician because you wanted to make $3 million a year. You became a clinician because you love helping people, treating people, talking to people, getting to know people. But you can't do that if you run out of business. You can't do that if you can't afford to keep your doors open. So we need to find that balance. I'm hoping to bring that to you. Guys, as always, if you like the content you're seeing, support the channel, subscribe, ring the notification bell, and post your comments and questions on the YouTube video. This way I know what kind of answers I can bring you that are going to help you succeed moving forward. Tony Maritato, welcome to Learn Medicare Billing and Credentialing. Guys, I'll catch you in the next video. Have a great day.